Good morning. I'm Amy Rowling McGee, the president of the Health Policy Institute of Ohio. Thank you for joining us for today's online forum, which will focus on preventing ACEs in Ohio, ensuring a strong start for children, and strengthening economic supports for families. The Health Policy Institute of Ohio is an independent and nonpartisan organization. Our mission is to advance evidence-informed policies that improve health, achieve equity, and lead to sustainable healthcare spending in our state. I want to start off by thanking our core funders who created our organization, many of whom created our organization almost 20 years ago, and who continue to advance our mission with their steadfast investments in our work. I also want to thank our 2022 educational event series sponsors for their generous support of our online forum series. This is the last forum of the year, and we have been able to make these available free of charge due to the generous support of these sponsors. And a special thank you to the Harmony Project for generously contributing to HPIO's ACEs work. We encourage you to tweet throughout today's webinar using the hashtag HPIO Forum. If you have any questions for presenters, please type them into either the chat or question box, and we'll ask them as time permits. Please also just keep an eye on the chat box too throughout the forum, as Carrie will be dropping some links to other relevant information in the chat box. We're also going to have some poll questions throughout today's forum and a few at the end, so please stick around for those as well. Today's presentation slides and other related resources will be available at the HPIO website and can be found by clicking on the Events tab. Adverse childhood experiences, otherwise known as ACEs, are potentially traumatic events that occur during childhood. Exposure to ACEs is a pervasive problem affecting many children in Ohio and across the country. Research literature generally groups ACEs into three categories: abuse, household challenges, and neglect. Physical abuse and substance use in the household, or emotional neglect. National data and analysis provides clear evidence that ACEs exposure is linked to poor health and well-being throughout adulthood, including disrupted neurodevelopment, social problems, disease, disability, and premature death. In addition, ACEs exposure has severe long-term cost implications at both the individual and the societal levels. In 2020, HPIO launched the Ohio ACEs Impact Project and released a series of policy briefs on the health and economic effects of ACEs, as well as elevating 12 evidence-based, cost-effective strategies that prevent ACEs before they happen. In October, HPIO released the first in a new series of ACEs briefs focused on analyzing the implementation status of 4 of those strategies in Ohio. Today, our speakers will discuss those 4 strategies in more detail. Those include early childhood education, early childhood home visiting, medical legal partnerships, and family income support. So to get us started, first, I'd like to introduce Dr. Tabitha Jones-McKnight, who serves as the Assistant Medical Director at the Ohio Department of Health. She's going to share some insights on the department's priorities and programs that support health and well-being of children and families in Ohio. Dr. Jones-McKnight, thank you for joining us.
Thank you, Amy. And I want to say good morning to everyone. And thank you, HPIO, for inviting the Ohio Department of Health to speak today about its efforts to assist in preventing and mitigating adverse childhood experiences in Ohio. Next slide, please. First, I'd like to begin by discussing a little bit about why we're talking about adverse childhood experiences. And I think Ms. McGee so nicely discussed that. With regards to our state health improvement plan, Ohio's vision is really to be a model of health, well-being, and economic vitality. And how do we accomplish that? It really takes all Ohioans being able to achieve their full potential for improved health status and reducing premature death. In the current state health improvement plan, there were 3 priority health outcomes that were identified as impacting that ability for Ohioans to achieve full health potential. They're mental health and addiction, chronic disease, and for children, this includes asthma, lead exposure and prevention, depression, suicide and diabetes, and maternal and infant vitality, which includes preterm births, infant mortality, and maternal mortality and morbidity. However, these outcomes and measures are based on several factors that shape our health and well-being. There are others, but these were identified as 3 priority factors in the state health improvement plan: community conditions, including access to quality and affordable housing, K-12 student success, and adverse childhood experiences, among others. This life course approach really acknowledges that what has happened to a child and family can have lifelong impacts on their physical, mental, and social well-being. Next slide. As part of that work, the Title V Maternal and Child Health Block Grant identifies a 4-year plan to address priorities for women and maternity care, infant vitality, child and adolescent wellness, and supports for children with special health care needs. For moms, the goals are to decrease risk factors that contribute to maternal morbidity. Some of the work that we have done through the Alliance for Innovation on Maternal Health. Also to increase mental health support for women of reproductive age and to decrease risk factors that are associated with preterm births, as you can see here on the left. For infants, we also want to determine how to support healthy pregnancies and improve birth outcomes. For children, focusing on improving nutrition, physical activity, and overall wellness for children. Looking over to adolescents, we want to increase the developmental approaches and try to improve upon systems to reduce adolescent and young adult suicide rate and promote protective factors and improve on systems that reduce factors that can be associated with higher prevalence of adolescent substance use. Finally, but not least, to increase the prevalence of children with special health care needs who receive integrated physical, behavioral, developmental, and mental health services. Across each of these, the goal is to prevent and mitigate the effects of children impacted by adverse childhood experiences. So these are cross-cutting system-building priorities. Ultimately, ODH works internally with partners in our local community, our local health departments, and other state agencies to really address community and social conditions and reduce environmental hazards that impact infant and child health. Next slide. Beginning with maternal and infant health domains, ODH has implemented the home visiting programs that provide expectant and new families with resources and skills with the goal of raising healthy, happy children who are ready to learn. The home visiting program also has the benefit of reducing burden of travel for families, and it is prevention focused. Next slide. So 4 of the goals for home visiting are to improve maternal and child health, prevent child abuse and neglect, encourage positive parenting, and to promote child development and school readiness. And these last 2 are really protective factors that help a child to be healthy. Next slide. Some of the core services that we provide in the home visiting program include identifying family-driven goals and action steps toward achieving those goals. Additionally, the home visiting program includes health and wellness assessments and screenings, some of which include adverse childhood experience questionnaires, the ages and stages questionnaire and social emotional questionnaires, also a comprehensive family assessment, postpartum depression screening, environmental safety, home observations and measurements of the environment tools, prenatal health screenings, and relationship assessment tools, as well as safe sleep assessment tools. Also, we utilize tools specific to specific models, such as the Healthy Families America and Nurse Family Partnerships, which many of you may be familiar with. For each of these screenings, there is a curriculum and a parent education that's provided. And once all that information is gathered, identified needs and goals have been assessed, then appropriate referrals can be made to begin to address those needs. For example, screening for and connecting families with resources for mental well-being, safe sleep, and other goals specific to an individual family can be valuable to maintain and create the conditions that help parents to thrive and ultimately help their children thrive. Next slide, please. One of the priorities for Governor DeWine is to expand and increase access to evidence-based home visiting, and he proposed increased funding for home visiting in his executive budget to accomplish this goal. The Ohio General Assembly approved $1.95 million per year of the current 2-year state operating budget. There have also been recommendations from the Governor's Advisory Council on home visiting to access all available state and federal funding sources to accomplish this. Next slide. With regards to that expansion, in 2019, 81 counties were provided with access to home visiting and the assessment tools, curriculums, and supports it provides. Since then, families in the remaining 7 counties in Ohio have access to home visiting services. In terms of choice of services, in 2019, 13 Ohio counties offered more than one model for home visiting, and that has since expanded to 16 counties. In the last 3 years, the counties that have nurse family partnerships has also increased from 6 to 27 out of our 88 counties. Next slide. On this slide, you can see, back one slide, please. On this slide, you can see the growth and expansion of the home visiting program over time since its beginnings from 2019 until now, and the projected goals for 2023. Next slide. So now we'll transition to some of the work in the child and adolescent space. Through grants through our maternal, child, and family health program that focus on adolescent resiliency, ODH continues to participate in work groups like the Ohio Anti-Harassment, Intimidation, and Bullying Initiative. And then we have other programs that provide resources and technical assistance and also offer professional development to health professionals who work in our schools, our early childhood programs to support resiliency among their students. Finally, ODH supports local communities to prevent violence and identify and respond to victims of violence through the Sexual Assault and Domestic Violence Prevention Program. Next slide. So how do we know what middle school and high school age children and adolescents are experiencing? So we have the Youth Risk Behavior Survey and Youth Tobacco Survey. This has long been a national tool for surveying about youth risk behaviors, and is conducted every 2 years in the United States to assess student health risk and behaviors in areas that have been identified to most likely lead to adverse outcomes. Given the strong relationship with risk behaviors and negative health outcomes, the Ohio Department of Health and Centers for Disease Control have prioritized the need to understand adverse childhood experiences among youth by asking about them on the high school questionnaire. And for the first time in 2021, 16 ACE questions and positive childhood experience questions were asked. And these will also be included in the upcoming 2023 survey. Positive childhood experience questions are equally as important to highlight the protective factors that may also lead to resiliency in children. Next slide, if you will. Additionally, in addition to surveying adolescents, the Ohio Department of Health has partnered with the Ohio American Academy of Pediatrics for their Safe Environment for Every Kid, or SEEK plus Injury Tool Quality Improvement Project. With this program, it's an evidence-based screening tool for families presenting for well child visits in children birth to 5 years of age. The screening tool goes on to identify and address the psychosocial risk factors for child maltreatment and injury prevention topics. The goal is to help practitioners identify areas where they can offer counseling or community resources to families, and it is available in both paper and electronic formats. The current wave, in wave 4, has focused primarily on rural communities where there's less access to pediatric hospitals and has had participation from about 20 healthcare providers across 8 practices in Ohio. Next slide. As a part of that Seek Injury program, providers complete monthly action calls with teaching sessions through the Ohio AAP. And during these teaching sessions, they learn about food insecurity, home safety, job resources, child passenger safety, among others, but also including ACEs. As a result of this, practitioners are making it a policy to really try to implement these screenings into their offices. Thus far, the results have been positive, with many of the healthcare providers being able to have impactful conversations with families, providers viewing this as an avenue to really address social determinants of health within their office setting. And they have been able to implement programs and services like the Triple P, or Positive Parenting Program. And this is supported by the Governor's Children's Initiative, ODJFS, and Ohio Children's Trust Fund, and Cribs for Kids. So far in wave 4, 791 families have been screened. As a result of the screening tools, 96% of families are receiving resources. And in previous waves, 1 through 3, collectively, there have been about 53 healthcare providers across Ohio who have participated. 1,277 families screened and 796 families who have received resources. Next slide, please. So that is an overview of the initiatives here at the Ohio Department of Health to prevent and mitigate adverse childhood experiences for children living in Ohio. And for further information about our programs, you may contact Diane Gogan-Turner. She is our Title V Program Director here at the Ohio Department of Health. I'll stop there and turn it back over to Ms. McGee. Thank you.
Thank you.
Thank you, Dr. Jones-McKnight. So please remember to type your questions in the chat box or in the question box. I'm going to take a look here and see if we have any. I don't see any in the question box.
Amy, are we good to move on?
I think we are. I am not seeing any questions there.
Okay, great.
Right,
well, I definitely noticed we have a very friendly audience this morning. It's very fun.
Yes, it's been great to see everyone's introductions. Please do that if you haven't already, because it's especially fun to see where from throughout the state people are joining us today.
And I saw that we have folks from a variety of sectors too. I've seen education, housing, criminal justice. So all very cool. We're happy you're here.
Wonderful. All right, Becky, take us away.
Okay, well, thank you so much, Dr. Jones-McKnight, for that presentation. There's obviously a lot of great work going on at the Ohio Department of Health right now. But now I'm going to move us to the next section of our forum today. My name is Becky Carroll. I am a Senior Health Policy Analyst at HPIO. And I am going to be talking through some evidence-based strategies to ensure a strong start for Ohio's children. As Amy mentioned at the beginning of our forum, HPIO's policy brief that was released in August of last year identified 12 evidence-informed strategies that meet the 3 criteria shown in these circles. Again, primary prevention means that the intervention occurs before ACEs occur, as opposed to screening or clinical treatment that would happen after the fact. All of these strategies also have a positive cost-benefit ratio and have evidence of affecting the ACEs with the most significant health and cost impacts in Ohio. And in our previous work, we found these ACEs to be emotional abuse, sexual abuse, and living in a household with someone who has a substance use disorder, a mental health condition, or who is incarcerated. As Amy mentioned, we plan to do a deeper dive to determine the extent to which these 12 strategies have been implemented across Ohio and how well they're reaching Ohioans in need. We will be doing this across 3 policy briefs. We just released the first one in October, and we plan to release the next one in mid-2023. In today's webinar, my colleague Jacob and I will be covering these strategies in these 2 areas. We will be doing a very quick overview of what's in the brief so that we have a chance to hear from some other folks on the webinar. But if you want more information on these strategies, please go to our website and download the brief. So it's important to note that when we think about preventing and mitigating the impacts of ACEs, we need to focus on promoting protective factors and reducing risk factors. Protective factors are assets and resources that promote resilience or the ability to withstand, adapt to, and recover from adversity. Risk factors are circumstances or conditions that increase a child's likelihood of being exposed to ACEs. Risk factors can occur at the individual, family, and community levels. And these factors may not directly cause ACEs, but they can contribute to environments where exposure to adversity is more likely. Research has made it clear that the first few years of life are the most foundational years for a child's development. However, we also know that ACEs negatively affect brain development and can also affect development of important systems of the body, which can impact a child's long-term health, education, and social outcomes. From a financial perspective, we know that interventions that target these early years get the most bang for the buck, so to speak. And the earlier these interventions are started in a child's life, the greater the benefit. The first strategy I'll describe is early childhood education. These programs typically serve children of ages 5 and under and provide enriching activities, experiences, and services to support health and cognitive and social development before kindergarten. So they help children build a strong foundation for future learning and school readiness. These programs can be especially beneficial to economically disadvantaged children who may not have educational resources at home or the support to help them learn and thrive. Research also suggests that access to affordable, high-quality childcare can buffer against a challenging home environment and reduce child behavioral problems, parental stress and depression, and rates of child abuse and neglect. As shown here, there are multiple publicly funded early childhood education programs in Ohio that serve families with low incomes, and eligibility criteria varies by program. In addition, there are also locally and privately funded programs in some areas of the state, which help to expand access to these programs and increase the quality of the programs in the communities. One example we highlight in the brief is Preschool Promise, which serves Montgomery County. It's important to mention that not all early childhood education programs are equally effective at producing positive outcomes for children and families. Step Up to Quality is Ohio's 5-star quality rating and improvement system. It promotes and recognizes early care and education programs that meet quality standards and exceed health and safety regulations. And all of these state-funded programs are required to participate. Despite the presence of all these programs across the state, many Ohio children in need do not have access to them. This graphic gives an idea of the reach of these programs. The reach of these programs for children living in families who earn below 200% of the federal poverty level. One recommendation we make in the brief is to expand eligibility for Ohio's publicly funded childcare by increasing the maximum income eligibility level above where it currently is at 142% of the federal poverty level. Governor DeWine recently released a bold beginning document in which he said that he intends to work with the legislature to increase this level to 150% of the poverty level. Now I'll turn to early childhood home visiting. You already heard a nice description of this, so I won't repeat that information. I will mention that evidence-based home visiting programs are an example of a multi-generation strategy, which means that they help children by also helping their parents. And home visiting programs that are comprehensive and focused on high need participants are more likely to have positive results. There are a lot of different home visiting models, and each model works to achieve a unique set of outcomes. Of course, Dr. Jones-McKnight talked about ODH's home visiting Help Me Grow program, which is the largest home visiting funding program in the state. And she also mentioned that there is at least one Help Me Grow provider in every Ohio county using an evidence-based model, which is very exciting. So these are the 6 evidence-based home visiting models operating in Ohio. I will also acknowledge that there are other programs around the state not listed here that also provide home visiting services. The most pervasive model in Ohio right now is Healthy Families America. According to research evidence, this program reduces child maltreatment, improves parent-child interaction, and children's social emotional well-being, and promotes school readiness. It can begin prenatally or within the child's first 3 months and continues until between the ages of 3 and 5. In the interest of time, I'm not going to talk through all of those models, but I know you'll be hearing about another one, Nurse Family Partnership, in just a few minutes. This graphic presents data that was in ODH's McVie Needs Assessment. So the data is a few years old, but at that time, you'll see that only 16.9% of the estimated number of Ohio families in need of home visiting services were served by one of those evidence-based home visiting programs. As we heard, home visiting is a priority for Governor DeWine, and funding for it has increased in the last 2 biennial budgets. According to that bold beginning plan that I referenced earlier, and from what we heard from Dr. Jones-McKnight, it does seem like Governor DeWine intends to expand evidence-based home visiting services even further. However, as demonstrated by the bottom recommendation here on the right, there are other challenges such as workforce and capacity limitations that need to be addressed to expand these services in Ohio. Okay, with that background, it is my pleasure to introduce Robin Lutz and Jeannie Wycliffe, who will tell us about their home visiting program. Robin is the administrative nurse manager for labor and delivery at Ohio Health's Grant Medical Center. And Jeannie Wycliffe is the program manager of maternal infant home visiting at Nationwide Children's Hospital's Center for Family Safety and Healing. And then after that, Autumn Glover, who is the Senior Director for Community Health Partnerships at Ohio Health, will facilitate a discussion about the work they're doing to improve maternal and infant outcomes through Nurse Family Partnership. All right, take it away, ladies.
Thank you, Becky. And I'll kick us off really quickly with an introduction. So good morning again. My name is Autumn Glover. As Becky mentioned, I have the pleasure of serving as the Senior Director of Community Health Partnerships at Ohio Health. Ohio Health is committed to advancing the opportunity for every person to benefit from fair and just access to healthcare and the elimination of barriers to lifelong health and well-being. Our commitment, this commitment to health equity, is why we create and partner in programs like these to address the most pressing health challenges of the communities we served. I'd be remiss if I didn't say thank you to Amy and the Health Policy Institute Ohio team for inviting us to share how policy has created this tangible support for pregnant people and parents with young children living in communities made vulnerable. And thank you sincerely to the governor's administration and ODH and all the many hands for your continued support of this important access for families. We're fortunate that we get to do this work in partnership, which is why you have folks from Nationwide Children's Hospital and Ohio Health here. And we look forward to sharing with you the comprehensive evidence-based approach that we're taking together for Ohio families. As Becky mentioned, I'm joined by my colleagues, Robin Lutz and Jeannie Wycliffe. Robin is going to begin with an overview. And our goal here today is to really give you kind of practical, detailed information of how we implement these programs. And then she'll turn it over to Jeannie, who's going to share more. And we'll close with a discussion. We invite you to join us in the discussion in the chat. We'll do our best to take a look there. I do have a few questions that I think may be burning questions after you all hear from them, but we welcome you again to join us in the chat. So with that, I'm going to turn it over to you, Robin, to get started.
Hello, everyone. Thank you. Thank you so much, Autumn. I am privileged to talk to you all today. And what I'm hoping to do, for some of you may or may not be familiar with Ohio Health, we're a large hospital system. We have 12 hospitals. Our home visiting efforts began in our hospitals within Central Ohio. And so I just wanted to take you on the evolution of how we arrived at our collaboration with Nationwide Children's and ODH, and just as a system here in Central Ohio. And so let's see, I'm trying to advance. There we go. So to start our historical approach, since 1993, we were in high schools in a mobile unit. We had school-based healthcare centers, in Columbus's high schools, and we've been doing that for 30 years. And then in 2010 to 2016, we received a grant from HHS, which was funded for innovative home visiting programs. And we did a randomized control trial and did research utilizing home visiting. And then we also had a collaboration with our health department, Columbus City Health Department, in 2018 and 2019. We also joined with Celebrate One. Our mayor started Celebrate One with the city of Columbus to address our infant mortality rates. And then the confluence of all this together, the Ohio Health Strategic Women's Health Committee, our goals aligned with the Ohio Better Birth Outcomes Subcommittee on Home Visiting. And that's, so to look at the mobile unit in our history, we saw that going to the schools, overcame the barrier of access. And as a hospital system, we deliver more than 60% of all of the births in Franklin County. And so, we saw that a multidisciplinary team was super important. The registered nurses, social workers together, we even had a dental clinic, was extremely important. And we saw really impressive outcomes with that multidisciplinary team and going to the patient. And then the Teen Options to Prevent Pregnancy was our research study that we did. We had 600 teen mothers within all of Ohio Health, Central Ohio hospitals, within the 5 hospitals, and 300 in the intervention, 300 in the control group. We did home visiting using motivational interviewing, which is a topic all to itself, but it's what most home visitors utilize, and I think is the most important aspect of home visiting. But we we did that, and those results reduced rapid repeat pregnancy by 50%. And that was one of our goals for that home visiting program. We also addressed ACEs and the social determinants of health with our social worker. We provided IPV, intimate partner violence and depression screening within those home visits. At the same time, the Ohio Equity Institute, which I saw all the names as people joined today, and I saw that many of you were part of this Ohio Equity Institute from 2013, working as a state, and then with Dr. James and Dr. Imes were our local partners there. And then we had, again, the establishment of Celebrate One, which I talked about here in Franklin County, to address infant mortality. So upstream, we were working on the policies and procedure. Downstream, we saw very particular zip codes where infant mortality and maternal mortality, where we had problems specifically, and we Celebrate One hired community health workers to connect people in target zip codes to clinical and social services. So these are all of everything surrounding what led to our collaboration, and which Jeannie is also going to talk to you about today with Nationwide Children's and the OBO. And OBO is Celebrate One's specific aim at maternal and child health outcomes. And so we, in 2016 as a system, we had a lot of meetings with OBO, and that OBO includes all of the hospital systems within Columbus and FQHCs. And I think that the reason I'm bringing this up is I'm hoping that this could be replicated throughout the state with the way that our city came together. I'm really proud of how Central Ohio came together to address our infant mortality and maternal mortality rates. And of course, I think the confluence that what we're talking about today, the ACEs, the research with ACEs was just integrated in everything that we were doing. Dr. Bruce Perry came here to speak to us in Columbus, and that informed a lot of our decisions within OBO, within Celebrate One, and we're very thankful for that. So the goal of OBO was maternal home visiting, access to contraception, prenatal care, QI data, and to address racial bias. And then out of that, in 2020 came the Central Ohio Visiting Collaboration, and that was created specifically to accelerate implementation strategies for healthcare systems who serve newly pregnant and parenting moms and families. So, and I just think it's important, again, to give the hospital perspective, because we need to reach mothers to engage them in home visiting. And I think to look at the whole continuum of maternal child health care is really important, to start prenatally and through birth, and to touch every part of the inpatient and outpatient setting to increase our numbers in home visiting. So this home visiting collaborative was created, and it had all of our Central Ohio hospitals. Mount Carmel had their own. Mount Carmel is our Trinity Healthcare Systems, in case those of you who might not know about Central Ohio hospitals. So our Trinity hospital system had their own, home visiting program funded by their foundation, and OSU utilized the health department in Columbus, and we at Ohio Health were doing our research studies that I've talked about, and NFP was starting to expand on their Help Me Grow home visiting and NFP programs. So the decision was made to come together and work through Celebrate One. All of the hospital systems contribute to Celebrate One in this OBO effort. We all financially participate in that. And then we also have several committees within OBO where we participate to look at health outcomes together. So we all came together. Some of the lower lights and Root are our local agencies who also came together with home visiting, and we formed this collaboration. And I have a few slides here that I'm going to rush through just because we did some PDSA cycles when we joined, because it was a big change. We were used to doing our own patients and our own home visiting and our own thing. And I think all of our hospital systems had the same issues. So we did some PDSA cycles to see how we could increase these home visiting referrals to our newly established home visiting system, within, centralized location. And it took a couple years. I have a couple slides here, just total referrals. You can see that from 2020 to 2021, we went from 269 referrals to 670. And we overcame some barriers. We have 18 clinics we were working with. And so we learned that we need to really engage those clinics and key people in the clinics to ensure that they do the referrals to the home visiting. We also utilized the electronic medical records. We have an automated button, and that takes, I don't know if any of you have worked with EMR, it takes a long time to get that going, but that was a huge success for our referrals. So I'll leave this slide for discussion, just some of our lessons learned, challenges, a lot of, just I think siloed stands out on that challenging list. A lot of us were in our silos working, and maybe some of the rest of the cities in Ohio, had that experience. We definitely did here in Columbus. We needed to come together, and we worked really hard to come together. And I'm really, really proud of the relationships that we have. And I'm going to let Jeannie go ahead and talk about Children's and where it's centrally located, the home visiting. Go ahead, Jeannie.
You're muted, Jeannie.
Thank you. I am the program manager for Maternal Infant Home Visiting Program with the Center for Family Safety and Healing with Nationwide Children's Hospital. The Center for Family Safety and Healing is a child advocacy center. And the Maternal Infant Home Visiting Program is housed with that center because it's an arm of our child abuse prevention program. We are implementing 2 evidence-based maternal infant programs here, and one, has been mentioned previously today, is Nurse Family Partnership. And that program, we have 5 teams that consist of 5 nurse supervisors, a supervisor per team, 20 nurses total amongst the teams. NFP teams include Ohio Health nurses, and which connects to or references what Robin previously mentioned, the partnerships that we have with other hospitals within the system and are partnering together to support the community. We are also serving 8 Ohio counties: Athens, Delaware, Franklin, Guernsey, Marion, Morgan, Muskingum, and Union counties. The other evidence-based maternal infant home visiting program that we're implementing is Healthy Families America. And we have 3 teams, which consist of 3 supervisors, 6 social workers. 4 of our home visitors are pre-K through 1st grade educators. And we also have 2 nurses on our HFA team, which is representing our partnership with Mark Carmel Health System. And our Healthy Families America program is serving 3 Ohio counties: Delaware, Franklin, and Union. Our funding for NFP is threefold. We are receiving funding from Nurse Family Partnership Incentive Fund, which comes from their service office. The Service Office of Nurse-Family Partnership is generous with supporting programs throughout the country, throughout the nation, who are either implementing NFP for the first time or who are expanding NFP in other areas. And we have been able to receive fundings for expansion. The McVie Fund also is funding 2 of our NFP teams out of the 5. And one of those teams is expanding, is our expansion into Southeast Ohio, which includes Athens, Muskegon, Morgan, New Guernsey counties. Ohio Department of Health is a funder through Help Me Grow Home Visiting, and Ohio Department of Medicaid, which we are starting to participate in. And this fund will allow us to expand NFP to multiparous women or women with multiple live births. Background of NFP, original target population based on its research is first-time moms. The goal is to enroll mom 16 weeks, but not after 28 weeks. It's evidence-based maternal infant home visiting model. And the outcomes include increased breastfeeding for baby birth to 12 months of age, a decrease in preterm births, a decrease in smoking and drug use, management of hypertension, and increased other preventive health practices, improved child health and development, improved economic stability through exposing clients to opportunities that supports families with development and completion of goals towards self-efficacy, education, family planning, and job skills. All of the outcomes mentioned also impact positively ACEs. HFA background, target population is first or multiparous moms. Ideally, we want to enroll prenatally, but HFA, we do and can enroll clients with infants up to 6 months of age. And the outcomes of Healthy Families America is increased parental knowledge of child development, physical and emotional. HFA outcomes supports a quality home environment, promotes positive parent-child interactions, improves family health, stresses, and the importance of well care, depression screenings, and prevents child abuse and neglect. Maternal infant home visiting, our target populations, NFP, again, as I mentioned earlier, first-time mothers, and we want to enroll between 16 and 28 weeks gestation is the goal. Women with high-risk diagnosis, current or history of substance abuse, adolescent pregnancies, immigrant, currently experiencing or history of mental health challenge, homeless or currently in an unsafe or insecure housing situation. Target population for Healthy Families America, pregnant women, families with an infant who is 6 months old or younger, current or history of substance abuse, adolescent pregnancy or mother, immigrant, currently experiencing history of mental health challenges, again, homeless or currently in an unsafe or insecure housing situation. So you've noticed that the target populations are pretty much the same of what NFP for NFP and HFA. Our challenges and barriers, staff recruitment and retention, hiring for diversity in race, culture, and gender, exposing the community to NFP, HFA, and other maternal infant home visiting models, safety for clients and home visitors. I think we all know or understand that hiring for diversity and race, culture, and gender is very important. When we are caring for folks, it is an advantage for them and for the home visitor if the person presenting the services looks like them or has had similar or same experiences that the family is having or mom has had. I am going to toss it now to Autumn.
Thank you, Jeannie, and thank you so much, Robin. I've been watching in the chat. There's a couple questions that I was planning to ask, so I'll get to those, but I wanted to start first in our discussion with really referencing something that Becky mentioned earlier, just really centering on the purpose of today's forum around ACEs. Becky mentioned prevention and protective factors, and I'm wondering from maternal and infant home visiting impact to ACEs, how are you all seeing that? What does that have to do with ACEs and really creating resilience in a family? Maybe Robin, do you have any thoughts around prevention, and Jeannie, if you might share some protective factors for us?
Sure. I really feel like Dr. Folletti's research on ACEs in '98 enlightened all of us to some of the challenges that have been addressed all morning. And then it just so happened that Dr. Olds, the developmental psychologist who was the developer of NFP, and is a prolific writer. He's created, published several journal articles about how nurse-family partnerships and home visiting addresses ACEs and trauma. It was designed as a child maltreatment program. But I feel like I want to take the opportunity, just as a nurse who's been in the hospital, who's been a nurse in the schools and in the clinic, in every setting, to try to understand how to increase a mother's to better mother and baby's health. I feel like walking into their home is like walking into sacred space. Just to the power differential is gone. You sit down with them and meet them and listen to them and hear them. And I feel like Dr. Folletti himself has a quote, it's just the opportunity to be heard, understood, and accepted by the home visitor can be a powerful experience for the ACE survivor. So I think that is a pretty general answer. Jeannie, I know you might have some more specific protective factors.
Yes, I agree wholeheartedly with Robin when she mentioned that going into the home, how the home visitor has to humble themselves and actually recognize that that person, that client, that family that you're visiting in the home is actually in control, which is different for us in healthcare, because we are used to the ones being controlled, especially when we're working in the hospital or seeing people in clinics. Both NFP and HFA give the way that the programs are implemented, the way that they are written, the way the models are intended to be implemented, to implement them to fidelity, true fidelity, to get the outcomes that are desired. You truly have to recognize that mom is the center. She is the person that is controlling or has the answers best for what's best for her and her family. And in order to help mom to meet those outcomes that I mentioned earlier in those screens, on those slides for both NFP and HFA, it's very important to develop a relationship, to engage mom, to ask mom the appropriate questions and conversations to help understand what her desires are and what barriers she's experiencing to keep her from being the best parent, the best mom for herself and for her family. Sometimes that might be, I want to finish school, or I want to get out of a relationship that is not safe for me and my family. I want housing that's mine. And then the nurse or the home visitor doesn't have all the answers, but the home visitor can work with mom and help to identify other resources in the community.
Thank you. I love that you both really highlighted just the truly unique opportunity to connect with families and really centering on the mom. There was a question in the chat, a little reference to something you mentioned, Jeannie, around the identity of the nurse, the community health worker, whoever that home visitor is. And I know we talk a lot about the barriers to success for the family and even success for us to provide that holistic support, and how important it is that the team is racially and culturally diverse. But I want to make sure I ask this question because I think for those of you who are thinking about how you might implement a program like this or how you might partner, recognizing that as Jeannie mentioned, the full fidelity of the program is that at the end of the experience, that the mom has had some mobility and improvement in her situation. So I'm wondering, maybe I'll start with you, Robin, just because you were a home visitor, if you want to share with us just the impact and maybe some anecdotes of that experience with moms and families. And then maybe Jeannie, you can help us answer one of the questions we have in the chat around the diversity of the team and how that adds value to helping the families be more self-sustaining. So Robin, what are some examples that you might share with us about the impact of home visiting?
Well, I think, again, a lot of times we engage people when they are pregnant, through a clinic or the hospital, or maybe even at school. And we're in a hurry. When we're in the clinic, we've got 15 minutes at most, and we have a series of questions we have to ask through the EMR, and we're guiding that conversation. We're driving questions at them. And Jeannie said it so well, in the home, they're in control. I think that's why our motivational interviewing research went so well in our first home visiting program that was, HHS's innovative bucket of funding. I think motivational interviewing, because the bottom line facet of it is to help patients with self-efficacy and understanding that they're in control of their health. And so I think that was the first thing, is to go into their home on their terms with their decisions on what they wanted to talk about. We had a Monopoly game, and they got to choose, what topic they wanted to address that day. And to help them understand their ACEs, we listened about their ACEs, and we helped them understand that they built resilience that people their age a lot of times don't have. And we can use those qualities to help them to ensure that their children don't have to go through what they went through, and they can stop with this generation. I feel like for me, going into the homes, I also was met with problems that I hadn't seen before in the clinic. I wanted to help someone get a job, and to get a job, you need an ID. So she didn't have a license. In fact, her mother had stole her license because her mother had substance use disorder. And so just going through probably 5 hours of work to get her a driver's license before we could even move forward to the next thing. It's just unpeeling layers and layers of difficulties that we may not have experienced ourselves. And just listening to the bravery of a lot of kids that are out there by themselves, and trying to raise children by themselves without support. So like I said, it's an honor to walk into their homes and help them.
Thank you, Robin. And I think the cultural humility that Robin and so many of our teams who don't share identity with the clients is really important. It's hard to hire for that. I mean, we're very fortunate to have folks. We do offer significant training, just responding in the chat. But I know Jeannie is very diligent in thinking about the design and the hiring of our home visiting team. So I wonder, Jeannie, if you have twofold question. One, kind of really affirm the importance of the diversity of the team, as you mentioned, but then also kind of how you've seen that demonstrated in the impact of having that on the team for the families.
Yes, the importance of having a team that's diverse, or a team that as close as possible represents the clients that we are serving. It helps with the engagement. We've actually had clients, moms say to their home visitor, "Oh my gosh, it was so much easier having the conversation with you because you too are an immigrant." Because the home visitor is sharing. They start sharing what their experience is like when they came to the United States, or to this country for the first time. Some of the obstacles that they were up against. Often our clients think because we are professionals that we have not had some of the same experiences, or have not had to overcome things. So part of the engagement, the relationship building, the trust that is developed between the home visitor and the client starts with the home visitor being vulnerable and being willing to share. Not to the point where the client knows all the home visitor's personals, but just to the point that the home visitor makes themselves more human, more approachable, more relatable to the client. And having home visitors, having folks on our team who represent our clients is extremely helpful for our clients. It's also helpful because if the example that Robin shared with having a client whose parent stole their identity, stole their ID, and having to help that client recover that ID and what those steps look like. There are many of us who come from a space that's not something that we would experience. But having a home visitor who knows what that's like, who has experienced it, or who has had another client that experienced it and can share some of what that means, what it feels like, it's easier for that client to be able to say, hey, I know I should have my Social Security card, but I lost it. I don't have a safe place to keep it. Or, we've been homeless a couple of times, and all that important paperwork was something that I didn't grab when I had to leave this house quickly. And so when we are hiring and interviewing candidates, we ask questions to help us to see what type of experience the candidate has had in the past, what their comfort level is with working with families who are in situations that are vulnerable for them, and how they respond to that. And often it's not easy trying to hire or hiring diverse teams. So what we do also is to provide a variety of education to our staff. We help put them in the position where they can ask direct questions about what it's like to be an immigrant. So what can we expect if I have a client that is from another country? If they're undocumented, what is my client going through? What type of barriers are already in place for my client who is undocumented, or my client who is coming here from another country and who are by themselves? What can I do to make things better for my client and remove barriers so we can press on and help them through a healthy pregnancy so they produce a healthy baby?
I love it. One of the questions in the chat, I'll take us off a little bit from my list, but one of the questions in the chat was around how do we replicate this? So I think, I'll start, and certainly Jeannie and Robin, if you want to share any of the secret sauce that we've learned over the years. But I think a huge part of the replication is the model. So hopefully it didn't feel too rote to have Jeannie and Robin walk you through, but staying focused on your focus. So the core kind of issues that we're trying to address are big and comprehensive. We're trying to make sure mom and baby are healthy in all dimensions of their health. So are they housed? Do they have other social needs addressed? So I would say that's the first thing from a replication perspective, and any funder, frankly, they want to know that you're doing kind of the evidence base. That's the purpose of replicating the evidence-based model. I think in terms of replicating the building of trust, I've done community engagement for many years, and there's nothing that will ever be able to replace proximity. So, as we have been working together, we've talked a lot about, home visiting is new to some, but it really is decades old evidence that, being close to and having proximity to the community makes the difference. And so the replication factor is finding teams who want to do that. And I know Robin and Jeannie both have interviewed candidates who didn't really understand, like, yes, we are actually going into their homes. It is more than proximate, but I wonder, Robin and Jeannie, for a question around replication, what would you say, or just beyond the kind of follow the evidence base, but how would you say we could best replicate the work? And certainly we've been scaling across the state. So maybe you have some thoughts in response to that question.
I think your first response, is correct, Autumn. I mean, it's a curriculum. It's, they need to be done to fidelity. One thing that we did when we were doing an innovative program, if anyone would want to, most all funding is for evidence-based programs, but we did get some funding for the innovative program from HHS. And with that, we immediately trained everyone in motivational interviewing. There are motivational interviewing trainers called MINT trainers throughout the state. And we did weekly sessions for 3 years with that MINT trainer. It was very important to understand how to help the patient with self-efficacy and listen and be present with them and ensure that they were being heard with reflections. And I know, there's a pretty rigorous training for NFP and HFA. Our earlier speaker talked about the specifics in the curriculum and some of the tools through ODH that we use. So if you'd want to replicate, you would, need to go to that training. And we'd be glad to help you with that. Jeannie, do you have any other guidance there?
I don't think anything different than what you or Autumn have already said. Replication, truly sticking or staying true to the model, staying focused on what the outcomes are. As you all probably already know, this work has a lot of pieces to it. And it's important to have someone amongst your group, amongst your agency, who's responsible for making sure that all the pieces are in place. Keeping track of what you're doing. Both models will sort of do that for you. But at the same time, it's important for you to have a process in place where you could individually, your program can look and say, hey, we're breastfeeding is an outcome. How are we doing with that? How many of our moms are actually active in breastfeeding, and how long are they doing it? The program's goal, for an example, might be 3 months out of the child's first year. It's okay for a program to say, you know what, let's see if we can ramp that up a little bit to 6 months. If we can get our moms to, be active in breastfeeding for 6 months. So then that's just an example. But I say being true to the model that you choose for your program, being focused, the education piece, making sure everyone is trained, being willing to partner with others within your community. The partnerships that we have with Ohio Health and Mark Carmel, for an example, have been great for us in reference to our being able to reach out to the community in reference to referrals, for an example.
And
Thank
I
you.
would just
Oh, go
also say we're so fortunate in Ohio. You know, we worked with the Crittenden organization, Directions for Youth and Family, because of their work with Case Western, with Folletti's research. And then we also, Dr. Ammerman's article, it was called Intensive Home Visiting is Associated with Decreased Risk of Infant Death. And it was in 2007. It still sits on my desk today. He really compelled me to look at home visiting. I feel like, and he's from University of Cincinnati with Dr. Kahn, who we're going to hear from. So there's just, you know, our trauma work in Central Ohio and in all of our cities. I'm seeing some of you talk about Toledo and Clark County and different places where this trauma work is going on. We're very fortunate in Ohio to have so many academic institutions that can help you to begin work to address ACEs and trauma within home visiting.
Thank you, Robin and Jeannie, so much for this conversation. We could talk about this all day long. As you can tell, we have the experts at our fingertips, and I'd be remiss if I didn't close and just say that we're really fortunate to have this as a state priority, and certainly the governor and ODH and Ohio Medicaid have really recognized the positive impacts of maternal and infant home visiting. What I think we all dream for is just to maintain that expanded eligibility. And I think our leader, our first speaker this morning, told us that we're not in all 88 counties. And so, you know, as we are in the season of making wishes and thinking of positive things and momentum in the future, I think our greatest hope is that this impact will become truly a standard of care, and that we'll really be able to support families across Ohio. As we close, I will drop our emails in the chat. I know there were some questions about training and how we engage CHWs and others in the model. Jeannie, myself, and Robin are more than happy to chat with you offline. And thank you again, Health Policy Institute Ohio, for having us.
Thank you. Thank you so much, Autumn and Jeannie and Robin, for joining us today. I had coffee with Autumn a few weeks ago and learned more about the partnership work that they're engaged in. And that's what led to the presentation today. And I was, learned even more today about the great work that they're doing. Our work here at the Health Policy Institute of Ohio starts with data and starts with evidence, and then uses both evidence and data to put forward policy options. So please keep in mind how you can personally influence the policymaking environment with the information that you're hearing today. So think about opportunities to engage with your local elected officials, your state legislators, those city council people, county commissioners, those who are charged with public policy making, and then think about ways in which the information that you're learning today might be applicable to your work and to private sector policy making as well. I think we're going to pause here and not for questions, although please continue to put your questions in either the question box or the chat box, and our presenters will respond as they're able. We're going to do a few poll questions though here to gauge how you're feeling about today's forum so far. So there's a few questions here. I believe there's 5 total. So please remember to scroll all the way down to the question box and just give us some quick responses on the presentations that you've heard so far today. All right. Well, I think next up on our agenda is Jacob Santiago, who is also with the Health Policy Institute of Ohio. So as Alana closes the poll, Jacob will get ready to do his presentation.
Thank you, Amy.
And again,
I'm going to give everybody just another second or two to answer that poll, and then we'll move on. So thank you all for your participation. I know there are a lot of questions. Please go ahead and enter your responses, and we'll get going.
And that voice is Alana Clark-Kurt, who is the producer of our educational forum series.
Thank you, Amy. All right. Jacob, take it away.
All right. Thank you all again for joining us today. And thank you, Amy. As she said, I'm Jacob Santiago. I am a health policy analyst at HPIO, and I will be walking us all through the policies and programs under the Strengthening Economic Supports for Families section of the ACEs brief. Family economic supports are a key method of preventing and mitigating ACEs in Ohio. While several policies, programs, and practices can fall under this strategy, we elevated 2 evidence-based cost-effective strategies in this brief: medical legal partnerships and family income supports, including the Earned Income Tax Credit. These strategies can support the economic well-being of Ohio families and ensure that they have access to necessary supports. We'll first look at family income supports and the EITC. Family income supports encompass several specific programs and policies, including the Earned Income Tax Credit, the Child Tax Credit, Temporary Assistance for Needy Families, or TANF, unemployment insurance, and many more. These programs can reduce poverty and increase employment, among other outcomes, and may also address many of the physical, social, and economic conditions that contribute to ACEs and their generational impacts, such as some of those risk and protective factors that Becky talked about earlier. The Earned Income Tax Credit, or EITC, is a prime example of a family income support that prevents and mitigates ACEs, such as mental illness in the household, and has a positive cost-benefit ratio. The EITC is a tax credit available from both the federal government and several state governments, including Ohio. The credit can be used by people earning income up to a certain amount to pay owed taxes on their annual tax return. The amount of federal credit available for taxpayers increases for every dollar they earn up to a maximum amount before plateauing and then decreasing until no credit is available. Marital status and number of dependent children in the household can also affect the amount of federal credit available. Ohio's EITC, like all state EITCs, are worth a percentage of the federal amount. Ohio's is 30% of the federal EITC and is non-refundable. This means that any credit left over after being applied to taxes is not issued to the person as a refund, leaving many Ohioans, including those with the lowest incomes, without the credit's full benefit. The federal EITC and most state EITCs are refundable. Ohio has already taken steps forward to improve the state EITC. In 2019, the General Assembly increased the state credits amount from 10% to 30% of the federal EITC and removed the $20,000 income cap. However, the non-refundability of the credit remains a large gap in Ohio's EITC. By closing this gap and making the credit refundable, Ohio's EITC could reach more Ohioans, including almost 380,000 Ohioans in the lowest income bracket, who the credit would reach or be more valuable to. Now I will turn to medical legal partnerships. These partnerships, also called MLPs, integrate legal services into healthcare settings. Legal services are provided by legal aid, pro bono lawyers, or law professors and students. They are funded through a variety of sources, including philanthropy, federal and state dollars, and health systems. MLPs affect several outcomes, including reduced stress, improved child and family well-being, and other mental and physical health outcomes. MLPs can also reduce disparities, including for people with low incomes and immigrants and refugees. As of June 2021, there were 23 MLPs operating across the state. Most are concentrated in Northeast Ohio around Akron and Cleveland, with 12 MLPs operating in that region. Southwest Ohio has the second largest concentration of MLPs, including some operating in Dayton and Cincinnati. Most Ohio MLPs work with infants, children, and families, but some partnerships work with immigrants and refugees or other populations. The only statewide MLP is operated by Equality Ohio and works with LGBTQ+ Ohioans. The fact that MLPs are operating in every region of the state is one of the many strengths Ohio has around this ACEs prevention strategy. There is also a lot of local financial support for MLPs, specifically from philanthropic organizations. However, as displayed in the map on the previous slide, MLPs are concentrated in Northeast Ohio, and not every county in a region of the state is served by the MLPs in that area. So more work needs to be done to ensure Ohioans in other parts of the state are able to access these services as needed. A lack of sustainable long-term funding contributes to this lack of MLPs operating in Ohio. To improve this, state and local governments can support MLPs by embedding line items into their budgets to support partnerships. And health systems can also work to integrate legal and social service needs screenings into their regular care to ensure patients can be connected with needed services. I will now turn it over to our next panel to take a deeper look at Ohio MLPs. It is my pleasure to introduce Dr. Robert Kahn, Vice President for Health Equity Strategy and the Fisher Child Health Equity Center at Cincinnati Children's Hospital, and Marie Curry, Managing Attorney at Health Education Advocacy and Law Project and the Veterans Project at Legal Aid Services Incorporated. They will share some insights into their work and then move into a discussion facilitated by Carrie Almasy, a Senior Health Policy Analyst here at HPIO.
Thank you very much, Jacob. Dr. Kahn, I believe we're going to ask you to kick it off and share a little bit more about MLPs in Ohio and all the great work that's happening.
Great. Thanks, everyone. Well, first, thank you to HPIO for having us join you today and talking about a really important partnership. I also want to shout out an extended team, not all of whom could join us today on the call, but lead among them Elaine Fink, who's Managing Attorney for Child Advocacy at the Legal Aid Society Greater Cincinnati. See a host of other attorneys there and key clinicians and program leads here who have made this partnership so successful. I just want to give special thanks to all their work to do it. Can't remember if I now have, yes. So I wanted to start with this one and really in tribute to the speakers before and then the many programs that aren't being represented today, and point out that no matter how wonderful medical legal partnerships are, it is really all of these acting in a sort of symphony that's going to be required to get to great outcomes for kids. And this recurring theme today of great initiatives, but so much unmet need or reach that hasn't happened. And so while I'm going to go deep on medical legal partnerships, I just want to emphasize, imagine what could happen if we all focus together on some measure of all children thriving or all families thriving. And all of these were woven seamlessly together. And just in the back of your head thinking, even just connecting the prior talk on home visiting to legal advocates and to healthcare even more tightly, what could occur. All right, next slide. So I'm going to focus on what we call our Child Health Law Partnership. Oh, got to go back one. And a little bit of formatting off there. Sorry about that. But what the Child Health Law Partnership, or Child Health, is the innovative partnership between doctors, clinicians, and lawyers and paralegals between Cincinnati Children's and Legal Aid here in Cincinnati. Was launched over 10 years ago to address the social determinants of health and mitigate health disparities. So what do? We address families' unmet civil legal needs. We educate health professionals about the social determinants of health and make sure they know they have a great partner in the community who's really effective at addressing them, not just screening, but how do we screen and then hand off to effective partners? How do we recognize patterns of problems and advocate for system level change for policies and practices? And then just so you have a sense of who we are, we have 3 primary care clinics and 3 school-based clinics serving well over 30,000 kids, almost all on Medicaid. We have an on-site legal aid office in our biggest practice that's staffed 4 days a week. And as I'll go in more depth in a few minutes, the 3 top types of cases are housing, public benefits, and education. Adrian Hanais on our team created this really nice flow map. I'm not going to go in depth, but I just want to emphasize that these kinds of step-based processes are really important for effective partnership. So everybody knows each other's roles, and we're looking for when it works well and where there are gaps. But if you look all the way to the left, how do we screen reliably, effectively, empathically, authentically in a primary care setting or at a hospital setting, and at what frequency? All the way far to the right, the tip of the arrow, how does that whole process ultimately lead not just to continuing to repair and fix social determinants issues, but how do we look for system level changes? And then those supporting structures underneath so that each step goes well. How do we have a multidisciplinary curriculum that's educating providers and how to get them to legal aid? And how together do we look at the data to co-manage the program for greatest effectiveness? One of our key innovations early on is 2009, before electronic health records were really popular, was to build in social determinant screening directly into our well child care visits. And so you see to the left there a series of questions. They've evolved over time, but the nature of the questions and how we get the answers, but making it so that it is just a routine part of care and that the young physicians who begin their training with us from day one see health equity and the social determinants of health are really critical to outcomes. A second key component that's often missed is on the right there, which is building in the referral directly into the health record as well. So as easily as I can refer to a lung doctor, a heart doctor, a GI doctor, I can refer to legal aid. The referral zooms out of our system, ensures it's HIPAA protected. The lawyers are not inside our electronic health record, but it's really important for making sure the information handoff occurs and then for measuring our success in whether families are getting from our office to the attorney. So what has the impact been? Over the last 12, 13 years, we've made over 10,000 referrals, close to 10,000 positive legal outcomes for kids, well over 1.3 million in recovered benefits. So for example, if they've been denied a SNAP benefit and an attorney or an advocate is effective in getting it back, this is a significant undercount because it's hard for us to track how long those benefits are retained, but over $1 million for families. And really in the face of rising volume, our referrals increased by 20% during COVID. So that's 90 referrals to legal aid a month. And if we were to look at, top destination referrals for our families, I think maybe speech and language referrals are the only ones that exceed our legal aid referrals. So truly you can see how important it is for families and how important it is to build it into the flow of care. This just gives you a little more detail on the types of cases we are referring. The 44% on the left, the dark blue, that is advice or information. So it may not be a case needs to be open, but the family gets valuable information about next steps they can or should take. But the range of colors on the right reflect housing cases, secured education services, maybe an IEP that's been denied, obtaining medical insurance, basic needs. So often it's SNAP, TANF, SSI denials that are being appealed and so on. To make it go well, we have to do a fair amount of provider training so they know what the issues are and really what to help a family understand and expect from a partner from the community. So we'll make sure the trainees get out to the Free Store Food Bank, spend time at JFS, get some pre-clinic teaching and so on. And really importantly, at least when they're co-located, I would say the legal aid advocates are as if they are part of our team, even though they wear a different color badge. The residents and physicians and attendings and nurses and medical assistants all get to know them. And sometimes they've said it's hard to start the day in clinic without them on site. I wanted to just highlight one big impact study that just came out this year that we published with legal aid. It was assessing the impact of referral to legal aid on kids being hospitalized. And I'll walk you through it, but the top line there is, compared to similar kids, those who got a legal aid referral were 38% less likely to be hospitalized in the year after a legal aid referral. So what we did, we took roughly 2,500 kids who had been referred. We matched those kids to those who hadn't been referred based on age, illness, deprivation in their local neighborhoods, and simulated a randomized controlled trial. And so what you see here in orange are the kids in before the intervention and after the intervention. You see that large drop. The comparable kids or the controls are in green. And again, what you see, those who got legal aid had that significant drop compared to those who did not get legal aid. So I say this in part because it's a striking finding. And if there was a pill in medicine that led to a 38% reduction across all outcomes, you can imagine every pharmaceutical company would be going after it and every insurer would be willing to pay for it. And so as we get back to how are great programs like home visiting and medical legal partnerships sustained, I think showing these kinds of impacts are really critical. I'll just say out of these cases, so when if we get 800 to 1,000 referrals and a third of them or a quarter of them are housing related, how do we go beyond the case by case by case to looking for patterns? And so on the left is just the cycle we take where we had a case where we had one referral for poor housing. As we started to dig into it, it turned out there had been 16 referrals from over 19 buildings, but all owned by a single landlord. And it was really critical that clinicians wouldn't have recognized this, but legal aid recognized the common addresses and pursued a path in which tenant associations were formed, accounts were escrowed, and eventually an outside builder, a nonprofit builder, took over all 19 buildings to do rehab. And I like to say it would have been a lot easier for me to just double the asthma medicine and ignore the mold. But again, because of this powerful partnership, we're able to take on landlord and really work with Fannie Mae and others to improve housing for all 600 to 700 residents in those buildings. A very similar process I won't walk through around delays in SNAP benefits. One or two cases in which a mom worried about that the SNAP increase for the newborn hadn't arrived. Working with legal aid, Hamilton County Jobs and Family Services really changed their policy to expedite increases in SNAP benefits. So important pattern recognition leading to policy change. I'll just tell you where we're going and then wrap. We are now, well, we've been doing this in the primary care setting and legal aid has been working on it in the prenatal setting. We're now starting to work with some of our subspecialists, and we've created a health equity network here at the hospital, which we're working with our psychologists and psychiatrists and asthma specialists, diabetologists to understand social determinants and refer to legal aid. Legal aid itself has established a new Center for Health Equity and Advocacy. And in that bottom right corner, we're really excited. We're talking with our value-based payer who has a risk contract with CareSource to see whether we can actually start using some of their dollars to directly support legal aid. So more to come there. I'll finish with just key ingredients: agreeing upon goals and priorities, investing in each other's mission and processes. So I deeply understand their strengths, but also their constraints on service, and they understand ours. We meet monthly to co-lead and co-manage the partnership. We do tremendous data sharing. So because it's in the electronic health record and it can link to their record, we can data share and manage against desired outcomes and difficulties. And we celebrate our successes and we plan the future together. So that'll stop. I'll look forward to questions. I'll take a look at the chat, but I'll turn it over to my colleague.
Thank you so much, Dr. Khan. Now, Marie, we're going to ask you to join us and share, if you could, a story of success that you've seen through your work with MLPs.
Oh, sorry, those were extras.
Hi, everyone. It's nice to see you. I'm so glad to be here, and I really want to thank HPIO for putting this together. It's exciting to learn about all of the solutions that are out there and to really put our minds to how to make them real for our families. Let's see. I have control over the slides. Next slide. So this is just a really high level introduction to legal aid. And so my legal aid organization is not the same as the one that Dr. Khan works with, but he and I have known each other for years because we all kind of work together and collaborate throughout the state. The Medical Legal Partnership in Central Northeast Ohio, where community legal aid serves clients. We've been operating since 2010, so a little over 12 years-ish. And you have a little bit of background on me because I always think it's good to know who you're talking to. And I don't know what I was thinking. MD is Maryland and SF is San Francisco. Sorry about that. Next slide, please. Dr. Khan did a nice job of kind of laying out and if you could just go through the animation on that, thank you. Laying out the kinds of cases that we see. And early in the MLP world, we developed this mnemonic called iHelp that helps give us kind of a helps particularly providers remember kind of the range of things they could be thinking about. Dr. Khan showed you that they have a screener built right into the medical record, and that has been an evolution. But this is a good mnemonic for many of our partners who are not healthcare providers. They're parts of other entities that are serving people. And so go ahead and run through that animation. So I is income supports and income stability. H is housing and utilities. E is education and employment. L is legal status, which we tend to think of as related to veterans or non-citizens, because immigration and veterans have their own kind of huge body of law that just relates to their relationship with the structures. And the P is personal and family stability, which we think of primarily as domestic violence and intimate partner violence. I'm not going to talk about any of those in any greater depth because we could spend all the time on that. And Dr. Khan gave you a kind of a sense of where those cases come from. Next slide, please. So I want to go ahead and jump into our story. If you could hold that for just a minute, I will let you know when to click the next animation. Dr. Khan gave you some great information about how a medical legal partnership works and what kind of outcomes we see and the range of issues that we deal with and how we use our cases and our community partnerships to inform our systemic and our policy work. So I'm going to switch gears and tell you the story about one of our client families who was struggling with both education and housing issues. And I, of course, changed everybody's name. So go ahead, please. We have been working with a family, we'll call them Ms. Peters and Mr. Abel, and their two elementary school children, Danny, two children, one elementary school age, one high school age, since 2017. Go ahead. This is a family that's facing numerous obstacles to health and income stability. One of the adults receives SSDI, so that's disability benefits for people who have worked 40 quarters. The other adult and both children have been determined to also be disabled, and they receive SSI, supplemental security income. So just in case you're worried that they're raking in public dollars, this income brings them to a household income for their family of four of roughly $27,000 a year, or 126% of the federal poverty level. So in 2017, we first received a referral for this family from Akron Children's Hospital because they were having problems with their poor living conditions. Lead paint, rodent infestation, lack of heat on the second floor of their home, but they were on a month-to-month lease. And when you're on a month-to-month lease, if you rock the boat, you risk having the landlord just terminate your lease with 30 days notice. Of course, the tenants are protected from retaliation if they raise concerns, but it's not easy for somebody to raise that kind of a claim when they're facing eviction. So at the first inquiry, we advised the parents that they were in a tenuous position if they wanted to complain to the landlord. And at that time, they didn't proceed with any action against the landlord. Go ahead, please. And in the summer of 2019, 2 years later, we received a new referral from Akron Children's Hospital because Ms. Peters and Mr. Abel were concerned about their 6-year-old child, Danny, being bullied at school. He's in kindergarten, right? In kindergarten, he had his glasses broken 4 or 5 times. He was thrown from a slide. The parents met with the school officials, but nothing was resolved. And Danny already had an IEP because he was suffering from PTSD, developmental disabilities, and other behavior issues. And his parents were concerned, had been concerned before he went to kindergarten that he was not ready to advance to kindergarten, but he advanced to kindergarten anyway. And at the end of the kindergarten school year, he was advanced to 1st grade, although the parents were again concerned that he was not ready. So legal aid agreed to represent the parents in the school concern. And over the course of several months and 4 school meetings following a new evaluation and a new IEP, so a new educational plan with additional supports, Danny was being served under an IEP that was better suited to his needs, but he still was not progressing. Because of his disability, he's eligible for scholarship money to attend certain schools, and the family decided to move Danny to a new school. The parents were then happy with the new school, and we were able to close this case with a good result. Now, meanwhile, Danny's sister Madison, who was entering high school at the same time in the fall of 2019, was also struggling in school. The parents thought she was several years behind academically. So she was really in a situation where she needed to have some attention. In addition, she had tested high for blood levels in the past, so that may also have been playing into her disabilities. She attended a charter school and she had an IEP, but the parents were worried that the school was reporting progress that was not actually happening. After the lawyer provided advice to the parents about how to advocate for their child, the parents attended an IEP meeting where the team members developed a new IEP. And following that meeting, the lawyer reviewed the IEP and gave the parents advice about how to monitor the progress under the IEP and what to particularly watch for. Next animation, please. So through the medical legal partnership, both children now have better opportunities to thrive in school. Now let's turn to housing. Next, please. The family had been in their house, a rental, for 6 years. There were 4 bedrooms and 2 bathrooms, which sounds like a big house, right? $650 a month in rent. So even in Akron, even before the pandemic, that was low rent. But remember, this family has significant disabilities and is on a fixed income that is only marginally above the federal poverty level. So when you hear the story and wonder, why didn't they just move? The answer is, where could they afford to move to? Even if the supply weren't tight and about to get really tight with the pandemic coming around the corner, they didn't have much income to work with. And incidentally, for various wonky and political reasons, our measure of poverty using the federal poverty level has not kept up with reality. So you remember I said before that the family was at about 126% of the federal poverty level. To manage to keep one's head above water, policy advocates calculate that people need to be between 250 and 300% of the federal policy of the federal poverty level just to tread water. That may sound like a lot of money until you consider rents, utilities, food, and transportation costs at a bare minimum. So when Akron Children sent this family to us in 2019, the family reported really awful living conditions, and we agreed to help them. And here's what happened over the next 3 years. First, we tried negotiation. In the fall of 2019, while all these school meetings were also happening and education worries were going on, we helped the family try unsuccessfully to negotiate with the landlord. The landlord was not responsive. Next, we helped the family deposit their rent in municipal court using the rent escrow process. I don't know if any of you have tried to use the rent escrow process, but it's not an easy process to use. And sometimes our clients who are distrustful of institutions resist this, and there can be pitfalls. Nevertheless, we moved forward with that strategy. After months of depositing rent in an escrow account at the courthouse and no compliance by the landlord, even though a court ordered the landlord to make repairs, Mr. Abril and Ms. Peters, with our representation, filed a lawsuit in the Court of Common Pleas in the summer of 2020. Mind you, so sometimes we're thinking, what, where's the enforcement of the building codes, right? The city had done their part. There had been numerous inspections, orders to comply, fines, and criminal charges, but no effect. So over the course of these 5 years, the family had lived with all kinds of problems. Inadequate heating, which I mentioned before, no heating on the second floor. Broken, cracked, and missing windows, dangerous electrical wiring, rodents, which is not a theoretical issue because Ms. Peters experienced a rodent running up her leg while she was in her bedroom, and another rodent attacked the children while they were in the family room. A downstairs toilet that wasn't properly affixed to the floor, peeling paint throughout the interior and exterior of the house. And remember, there are lead exposure issues in this house. An exterior facing door that didn't open and close properly, and broken downspouts that caused flooding inside the house and accumulation of ice on the outside steps, where both Ms. Peters and Danny had taken a fall. So there's a lot to be managing here. The landlord, right? We sued the landlord. The landlord tried to dodge the lawsuit and his liability to the tenants by absconding to another state 1,000 miles away. And it makes it really hard to sue someone if you can't serve them with court papers. But we were able to hire a process server and successfully serve him at his out-of-state residence. The landlord then tried to skirt liability by filing for bankruptcy. We represented Mr. Abel and Ms. Peters as creditors in the bankruptcy action to protect their interest as creditors. Remember, they'd been depositing months of rent at the courthouse, and we wanted to protect that money from being folded into the bankruptcy and split up among all the creditors. If that happened, the family might not have seen any benefit from escrowing that money for so many months. So new animation, please. Eventually we settled all three of the ongoing actions, and the major terms included that Ms. Peters and Mr. Abel were able to receive $18,000 of rent returned to them from rent escrow. Like, huge windfall. There's all kinds of implications that are going to happen for that, for their other public benefits. But still, right, this is an opportunity, creates an opportunity for them. They entered into a new lease agreement with the landlord with reduced rent, and they hope to buy a home using the money and move out. So the new lease secured them long-term housing, right? They have a new lease agreement, but also included a clause that allows them to terminate the lease in 30 days if they find alternate housing. So these kinds of situations are the things that our families face day in and day out. Next slide, please. So we see some themes, and I have lots of stories and examples to share with you about these, but the themes we see are that it's rarely just one problem, and it's always disruptive. You know yourselves how hard it is to solve health problems and school problems and anything payment related. The phone calls, the long hold times, the inconsistent answers, and the resulting frustration and confusion. When our families are facing these situations in multiples with a limited ability to figure out the best way to move forward, it's no surprise that they don't get good results. The medical legal partnership tries to help people navigate these systems that are designed to be complicated. And the theory behind structuring complicated systems is that only the people who really need them will go through this complicated process. But that's not the way it works in the real world, right? Instead, the people who need these supports are often the least able to navigate the rules and the requirements set forth by these systems. And as an additional challenge, our families experience tremendous loss. Many families who disappear for months, when they resurface, they share that someone died and their lives were completely upended. Maybe an elder whose disability benefits were helping the family pay rent died, and then the family faced eviction and was engulfed in the problem of finding new affordable housing. Maybe a sister died and her several children became part of our client's household, requiring all the challenges of school, trauma, financial implications, and maintaining employment that poses. And our clients uniformly are seeking respect, to be seen and heard. And that's really the foundation of the medical legal partnership. And the reason I just took 10 minutes to tell you this story is because we know in our heads the challenges our people face, but it's really important to ground that in actual people and to remember that these are lives that are everyday challenging, and the bumps that our people hit and the problem solving skills that they bring to bear every single day. They really deserve everything that we can do to help them thrive and move forward in their lives. So that's my piece, and I don't know if there are any questions.
Thank you so very much for sharing, Marie. Oh my goodness, what a wonderful example of the importance of this work that you and Dr. Khan and others are doing across the state. I don't see any questions yet, but I will keep that open. In the meantime, I would love to know, we heard from Dr. Khan that we've seen increased referrals during the COVID-19 pandemic. And Marie, you mentioned some of these challenges that the families are seeing on an ongoing basis. So either related to changes in the current environment or ongoing challenges that families are facing, what sort of policy solutions could benefit MLPs across our state?
I'd like to take a stab at that because we've had some success in Summit County. And Dr. Khan shared with you some of the great things that they have done in Cincinnati as well around housing. So in housing in 2020, just before the moratorium on evictions ended, the federal government's moratorium on evictions that was challenged in all of that, our city council in Akron passed 2 pieces of legislation to protect our tenants. One was source of income protection. So you couldn't be denied housing just because your income was coming from somebody else, like the CARES Act or coming from a federal voucher. That's great, but it's really hard to enforce that. It's really hard to have much teeth with that. But the really significant thing that we passed was pay to stay legislation. And what that means is that if a landlord seeks to evict a tenant solely because they haven't paid rent, which is what landlords often do, right? It's the easiest way to evict somebody is if they miss a rent payment, they miss a rent payment, one rent payment, they're late by 1 day, the landlord has the opportunity to evict them. So with this new pay to stay protection, if the family or the tenant could come up with the money that they owed, including late fees and whatever they owed, by the time of the court hearing, then the landlord had to take the money and let them stay. This was just huge. I mean, the number of people that we kept housed through the pandemic is just phenomenal. And with the CARES money coming into Summit County, that was really well integrated in our social service structures, it really worked incredibly well. And we see the difference just in the other municipalities that Akron Municipal Court serves. We serve Stowe and Barberton, so it's a couple of different municipalities where they don't have pay to stay legislation. The incredible difference, right? It's like, oh, you're in Stowe. So we can see how these policy level changes that change the landscape for everybody at once can really have a huge impact. And I mean, there are other examples that I could give you, but that's a really nice one.
Carrie, I'll just quickly add, I think changing the financing, like we say we want great health for all, it's 18% of the GNP, but it's going to healthcare. So if we really want health equity, what are the policies and regulations we can put in place to move effectively and efficiently some of the money out of healthcare and into social care, and not just, again, in a reactive way, but in a proactive way. And so I know our legal aid partners, struggle with how are we going to finance this program? 800 to 1,000 referrals a year. Someone's benefiting by a 38% reduction in hospitalization. The kids and families, obviously, but financially as well. So how do those savings get put into the system of social care?
Those are both great points. Thank you both so much for sharing. We really appreciate you coming and speaking with us today. If there are other questions, please feel free to pop them in the chat or in the Q&A, and we will get to them in the last couple of minutes if possible. Now I am going to ask Alana to move us to a poll that sort of highlights your thoughts and feelings about the webinar so far today. We'll give you a couple moments to vote there.
Thank you, Carrie.
And remember to scroll down because there are a total of 4 questions. I have made that mistake in the past.
Thank you, Amy. All right, we'll just give everybody a few seconds to do that. And then Carrie, I know you have a few more things that you want to share with the audience before we close out today. So we'll try to do that here soon.
I'm going to say, just chime in and say thank you to Dr. Khan and Marie, for being with us today and sharing such compelling data. And the story, Marie, was just spot on in terms of articulating the multiple challenges faced by families.
Thank you, everybody.
All right. And then finally, we wanted to share, as Amy mentioned earlier, that there are multiple ways that folks across Ohio can influence the policy environment to lead to changes like those that Marie and Dr. Khan mentioned, things including writing letters, providing district-specific data to your legislators, fact sheets, etc. There are many ways that you can be involved. So along those lines, Alana, I believe you have a last set of poll questions.
I do, and these are pretty quick. There are 5 questions, so like Amy said a couple times today, please scroll down. These are a little easier to answer because they're quite short.
We really appreciate your participation in these questions. It really helps us to know how we can improve moving forward.
Thank you, everyone.
Thank you. And thank you again, everyone, for attending our online forum today. Please share any feedback you may have about the event. In the survey, you will see when the webinar ends or by using the link on our events page that we shared earlier. Thank you all. We appreciate you.
Thank you. Really, we appreciate you too.
Have a great day, everyone.
Thank you.